so much. It's a pleasure to be here, as always. So from the neural talk, we are heading to the heart talk here. So the gut and the cardiovascular health. So I'm not a cardiologist. I'm an internal medicine physician practicing preventive and regenerative medicine. So technically a family physician where we had to look into everything in our day-to-day practice. So we are into preventive medicine. So when you're talking about cardiology or GI or any system of medicine, we tend to be in the focus of prevention and regeneration. So why we have to look at the heart disease is because who's at risk today. Lately, we are seeing a lot of risk factors. Previously, before COVID pandemic, at the same time, and after as well, we are seeing a lot of risk of heart disease. So 2017, we have 30.3 million US deaths diagnosed of only with heart disease. And then cost for the heart disease is in kind of billion now to trillion cost. So that's the reason we have to look at preventive heart cardiovascular this thing. So how do we prevent it? Treatment, yes, it's the same treatment as the regular cardiovascular treatment, but how do we prevent and how do we recognize? How do we recognize in our OPDs and how do we manage the prevention of cardiovascular disease? So as always, we see here all diseases starts in the gut. I think we have enough data as of 2024 and more evidence data that all the diseases start in the gut. And that's where we're going to go into depth and which we've been talking for years, but at the same time, here rightly focused directly into the heart. So dysbiosis, when we say dysbiosis, I think this talk has been, this dysbiosis word has been in the market for quite some time, okay, but not really looking into that what is really happening with dysbiosis. Here we call it as IBS dysbiosis. So dysbiosis, what happens technically in dysbiosis is here I'm going to highlight this time. It is the synergy, what is that dysbiosis? So when we're talking about this dysbiosis, every organ is affected. What is dysbiosis? Dysbiosis is the language of the microbiome. It's the microbiodata. So it is the language and exchange mechanism because the microbiome which causes the dysbiosis. So here we are going to focus more on the heart this time. So what is the language that they are being exchanging in the gut? It's microbiodata. So what is this? It's causing infection, which is going in the gut, okay, metabolism, which happens in the gut, as well as diet and microbial metabolites. Here we have to focus on microbial metabolites, which are very, very important. We are not there in terms of concentrating of the microbial metabolites. We know we have gut microbiome, we have trillions of microbiome in the gut. But what are they doing? Now everybody comes to prebiotics and probiotics. Prebiotics is nothing but food for the bacteria. Probiotics are the bacteria by itself. But in between this prebiotic and probiotic, there are metabolites released by the microbiome. So the bacteria which are commensals, could be infectious, but they release some metabolites. So the metabolites which are released by the microbiome also has a significant role in all the diseases that we are talking to. So here it is the diet microbial metabolites with carbohydrate, proteins, and fats. So when you're talking about carbohydrates, when we take intake of carbohydrates, there are certain bacteria takes in and metabolites are different metabolites. Protein, it's a different metabolite, and fats as well as it's a different metabolites. So we're going to go into this different bed. At the end, there is a plaque formation and atherosclerosis formation at the end with these synergy together. This is basically what happens in the gut. If we have more in one slide, if you want to know what happens in the gut, is gut microbial diversity. So you need that gut microbial diversity to gut microbiome to gut-derived metabolites. So this is the synergy between each one of each microbiome, which is causing these diseases. Look at the networking that is happening inside the gut. This much detailed networking happens, which can be positive as well as negative associations. So the positive associations are equally important as well as the negative associations which are happening. So it is not about only replacing the probiotics and the microbiome. Maybe we are giving the wrong probiotic. Maybe it is causing a negative association. So now, as of 2024, we have enough data of microbiome testing. So I, in my clinic, also test stool to see what kind of microbiome is there. We have a detailed report about what kind of commensals bacteria, which are probiotics or any kind of bacteria. We get a detailed report. Some microbiome causes more harm than benefit. So this is what the harm, the same bifidobacterium is causing more harm than when it is having the metabolite. So this is already happens. It's a carbohydrate, protein, and fat. So when we eat carbohydrate resistance, why we keep saying fiber, fiber, fiber? Why fiber is important? Why the same fruit which has fructose and the same sugar has fructose, how is it different? It's because of the metabolite which is different. So the same carbohydrate we take as starch, but you take as resistant starch dietary fiber, it can cause into the same TCA cycle, but it produces something called short-chain fatty acids. So this short-chain fatty acids is produced by the dietary fibers, whereas the normal starch doesn't produce the short-chain fatty acids. Now the same thing is lipid metabolism in the lipids and the fats. So when you're taking the fats they produce, we have as a lipid choline and L-carnitine is what the amino acids which can be expressed as. Now what is happening with this is bile acids and the TMAO, which will come into the depth which is causing the cardiovascular problems. And now protein metabolism. So there are protein diet, we want good protein, too much of going on we are deficiency in the protein. But undigested protein will have its own different metabolite which can cause a disease. So be careful of too much of protein at the same time. Because undigested protein, aromatic sulfur containing amino acids can have a different results for the microbiome. So metabolites are very, very key in terms of carbohydrates, proteins, and fats. So this is basically what is dysbiosis of the gut microbiome. So everything, the diet goes in there, but the microbiome reacts differently with its metabolites, and those are the metabolites with the bile acids, TMAO, and the short-chain fatty acids, and the fat with an LDL and oxidized LDA. So now this much mechanism and networking which goes on, which is directly involved with the lipid metabolism and inflammatory response and affecting your blood pressure. So if you don't have, again, same thing, renin, peripheral resistance, GPR, we have enough evidence that this is at what metabolite is being produced by the microbiome, and that metabolite is interfering with the genetic code, and what is it stimulating, or it is suppressing the inflammation. This is the whole summary in one slide when the gut dysbiosis happens. So bile acids, TMAO, these are the things which is short-chain fatty acids. If they are low, these are the genes which are getting affected and which causes interleukin 8, and myocardial fibers which can be causing interference. So short-chain fatty acids, again, it's a friend or a foe. There is a lot of confusion between, we thought it was bad, again it was good. Before the data is published, is it a friend or a foe? So short-chain fatty acids are our friends. So that's what happens with the butyrate. So the no more thing now, if you see in a product-wise, it's available in the market as acetate, propionate, and butyrate as supplements to these microbiome. So when they are there, they will be decreased atherosclerosis and decreased hyperplasia, decreased myocardial necrosis. Ischemic damage also will be less when you have enough short-chain fatty acids like butyrate. So due to the anti-inflammatory properties that short-chain fatty acids have a wide range beneficial on our body, including neurodegenerative disease, obesity and diabetes, and immunological conditions. So when you say the fiber, there are different kinds of fiber, soluble fiber and insoluble fiber too. So we need to understand when we are recommending fibers to the patients, what is it causing? So our back of the mind, we need to think, why am I recommending the fiber? What might it be causing? Because of the short chain fatty acids, which is having an anti-inflammatory properties. So this is again another summary of gut permeability. When you have an appropriate short chain fatty acids, which decreases the sympathetic activity, and endothelial function is better, blood pressure is reduced, decreased renin, and inflammatory responses in the blood-brain barrier and the gut bacteria and the reactive active species is less. So these are the short-chain fatty acids which you get from the dietary fibers, which is very important from a carbohydrate source. Now, dietary fiber, acetate, butyrate, and propionate, and there is some other toxins also which can cause called LPS, lipopolysaccharides. So they all go in hand. If you don't pay attention to all these details, then we might be causing more harm by giving our therapies than any benefit to it. So this goes in hand. When you have an endotoxin, which is called a lipopolysaccharide, which can cause an TNF alpha in tumor necrosis factor stimulation with an IEL6, causing inflammation and lipogenesis. Whereas when you have an acetate, it's causing the same thing in the liver called lipogenesis, and oxidation is decreased, reduced because of the glucose and insulin pathway. This is the pathway how your dietary fibers in a fruit, when you're getting short chain fatty acids, how is it different from a normal sugar. So coming to the infective pathway. Now these are the other, we have microbiome with its metabolites and we have infections, but there are some viruses and there are some bacteria which are not causing infection as an acute infection. There is no acute infection like a fever or other acute parameters, but there is a chronic infection. So the infection may be symptomatic or may not be symptomatic. So EBA, Epstein-Barr virus, we check a lot of Epstein-Barr virus whenever we can. Again, hepatitis B, herpes, Coxsackie, parvo B19. That is not in the prevalent, but as doctors, we see them a lot. And chronic fungal infections. So we have enough information about candida now, about gut candida, candidiasis, gut candida, which is causing the dysbiosis. So the candida is also a fungal infection, which is a big thing, and we do have fungus inside our body, but it is with the gut microbiome, it is stimulating, or it is what kind of metabolites the body is secreting. So coming to the bacterial toxins, which might not be causing infective pathway. So we have two different types of toxins, endotoxin and exotoxins. We know about exotoxins, which causes fever and low blood pressure. We are not talking about the acute management here. We are talking about the chronic infections, which are asymptomatic. So the patients are not coming back with fever or acute pathway. We are talking about chronic infections, which is called endotoxins, and then the endotoxins produce something called lipopolysaccharides, and these are gram-negative bacteria and are associated with cell walls of the gram-negative bacteria. So there is a difference between endotoxin and exotoxin. Okay, so there is not much, there is the way the presentation of the bacteria are different, and the presentation of the patients are also different. So potency, antigenic form for toxoid. So endotoxin is not a toxoid, whereas exotoxin is a toxoid which can cause the infection. Again, summary, bacterial overgrowth. So we call it as SIBO right now. Now what is that bacterial overgrowth? Bacterial overgrowth also causes bacterial translocation, bacterial endotoxin, which enters into the bloodstream, activation of monocytes and macrophages, releasing pro-inflammatory mediators. So inflammation is chronic, okay? Exotoxins are acute. Endotoxins can be chronically producing inflammatory factors by a bacterial overgrowth, impaired host defense mechanism, and altered gut barrier function. Now everybody knows what is a gut barrier function if you know this kind of approach. So dysbiosis is a gut barrier dysfunction. So we have these barriers of tight junctions with the adherent junctions right there in the intestinal epithelial cells. When these tight junctions are interfered, when these adherent junctions are interfered, that's where the LPS or lipopolysaccharides enter into the bloodstream. When these tight junctions are still intact, we don't get any of the lipozymes or any of the metabolites which is producing the microbiome. They don't enter into the bloodstream. So it's our responsibility to kind of take care of the tight junctions and adherent junctions. So when these junctions interfere, that's where we get all this neutrophilic and atherosclerotic formation and LPS, which goes into the inflammation and atherosclerosis. So this is a very good interplay between low-grade endotoxemia and vascular disease. So this is endotoxemia, which can cause chronic inflammation. So this is the same thing, upregulation of the junctional protein or downregulation of the junctional protein. So these are the junctional proteins which are being studied a lot because of the dysbiosis. So there is interference in these junctional proteins which are interfered and causes dysbiosis, which is crosses into the bloodstream. Then again, mechanism of LBS-mediated atherosclerosis. Again, lymphocytes, neutrophils, monophytes, again causing exotoxins or endotoxins. But again, LPS coming from the endotoxins can cause an atherosclerotic plaque by an inflammation. So post-viral also people come back with a lot of pain and a lot of discomfort and a lot of symptoms. So this is the inflammatory pathway which is still having an after effect of the endotoxemia and after the chronic inflammation. So this is what the post-viral, even though the acute episode is over, the inflammation still continues because of this pathway. So this is basically what happens when you interfere with the transcellular penetration of the antigens or paracellular penetration of the antigens. So you have these junctions called zonulin and occludin proteins which take care of the tight junctions. When the zonulin and occludin proteins are interfered and broken down, that's where you call it as a paracellular penetration of the antigens. If not, you can have a transcellular penetration also because of the food that we are taking in. The paracellular transmission also can be damaged. So what are we saying when it is a leaky gut? What is leaking? It's leaking through what? It's leaking through these tight junctions. So you need to understand what is leaking. Everybody gets an answer. What is it leaking? Where is it leaking from? Okay, it's leaking from the tight junctions of the epithelial cells of the intestine. So that's what the antigen measures. So we do have these kind of testing, and we can test, and not in India, but in US, we do have this kind of testing called zonulin testing, and that's how we diagnosed as leaky gut after the testings, and then we test all that. So this is the same thing, healthy gut and cardiovascular diseases, which the LPS and TMO inhibitor, this causes oxidative stress. So this is cholesterol accumulation, fibrosis and inflammation, and cardiovascular death, which is called a TMO. So this is, again, it's the same slide, I think. So what is the gut microbiota do? What is the good thing and what is the bad thing? That is it's a double-edged sword. It is actually a double-edged sword. If we don't pay attention, then we might be poking on the wrong side of it. So what is this responsibility? The gut microbiota hosts fitness, including host feeding, energy harvesting, intestinal homeostasis, drug absorption, toxicity, immune system responsiveness, and pathogen defense. This is the gut microbiome responsibility. But if it becomes the other side of the sword, what can it do? So they can also produce microbial products such as bile acids, such as triethylamine N oxide, lipopolysaccharides, vitamin B complexes, vitamin K, uremic toxins, nitric oxide, fatty acids in the short chain, gut neurotransmitters, hormones, can modify host metabolism and influence both the health and the disease of the working body. If you don't understand this, it's at the same time, the same microbiome is producing the short-chain fatty acids, and the different microbiome is producing the uremic toxins and the LPS and the lipopolysaccharides. So the name and the different microbiome is doing different responsibilities. Again, TMO is produced by the microbiome via ingestion of meat products containing nutritionally trimethylamine, such as phosphatidylcholine, glyceryl phosphocholine, trimethylglycine, betaine, butyrate betaine, and choline and L-carnitine. So that's where we come up with meats, processed meats versus fresh meats. Everybody says, okay, meats are bad, meats are bad. Maybe the processed meats are producing these TMO. We did not have this kind of an understanding from ages and from long time in evolution. People were hunting and people were eating meats, and that's why some people promote protein diet with a keto diet and all that also. So this is also, protein is also the same double-edged sword. What is a good protein and what is a bad protein? What is a fresh protein and what is a refrigerated protein? Maybe we made a wrong thing in, with this so much of, improvement, we are using processed protein and we are using frozen meat. Maybe that's what is causing too much of choline and too much of L-carnitine. That's why maybe you're having a TMO. So it's protein. You have to know what kind of protein is synthetic versus natural protein. So this is high plasma of TMO, which can cause endothelial dysfunction, inflammatory coronary arteries, atherosclerosis, and lots of inflammation. So this is a biomarker. It became a biomarker for any kind of ischemia and ischemic strokes. So this is the main thing, is a lot of data happening behind that. So this is a balance between these both. So when you don't have a same choline, L-carnitine, and betaine, too much of a meat diet, but it's processed, okay, the eggs are also processed and the eggs are also not natural. Maybe it's producing the wrong choline, and maybe it's producing, instead of the short-chain fatty acids, it's producing a TMAO, which is causing all these diseases. So it is a balance between the synergistic interplay between these two. It's the same microbiome which is producing the same thing, but it's a balance between, so what we are eating and what are we feeding the microbiome, and what is the gases that the microbiome is excreting. I would put it in that way, as simple as possible, that what are the gases that as metabolites, as the microbiome is releasing, which is causing inflammation or anti-inflammation. So again, choline, carnitine, betaine, dimethyl, these are the enzymes, causes intestine, and then it can cause flavonoids. Maybe that is what is causing the non-alcoholic fatty acids, and in the circulation, again, it is a recirculation which happens because we have a TMO reductase enzyme at the same time in our blood. Again, gut, summarizing it, why in the TMA, at what genetic level it's causing, and what is the platelet reactivity causing thrombosis. Again, addition, static electricity causing foam cells, TCA, negative correlation for the inflammation. And now where do we take it, and what medicine, therapeutic strategy also. We are having a therapeutic strategy how to decrease the TMAO. So the therapeutic strategy, they are using different kind of microbiome again, which decreases the TMO, and then metformin. That's why metformin, if you say anti-aging data, okay, nowadays the mostly anti-aging physicians, when I say anti-aging, it is not cosmetic, it is aging, and anti-aging in terms of that. Everybody, anti-aging physicians who wants to look into the longevity, so I would call it as longevity. All the doctors or all the research scientists who are looking at longevity, everybody is on metformin. Why? We ask the same question. In diabetic patients, we are using metformin. But if you look at all longevity data, they are on metformin and resveratrol. So what is that metformin causing, and what is this is as a medicine? Why they use this? After this data, that's why everybody started using metformin. So again, TMA is hepatic conversion, can cause plaque-specific microbiotic atherosclerosis, and maybe it causes diabetes too. So diabetes is maybe the N factor. Even though we are restricting our sugars, we are still having impaired fasting glucose, and we are still having HbA1cs more than 6, even though the person thinks he's doing a best diet and all that, but still the HbA1c is more than 5.7. It is not the glucose by itself, but because of the metabolites, it's the microbiome is causing. So the intestinal microbiomes. So again, heart and gut inflammatory bowel disease appear to be higher risk for coronary artery disease, despite a low preference of classical risk factors indicating additional links between the gut and the heart. Because if it's one department which has progressed significantly in terms of statins and of atherosclerosis is cardiology, progressed quite a bit, but still we are seeing these high numbers. Why is a question that we need to ask ourselves about why we are doing this, why it's happening. So healthy gut, again leaky gut, again if you see normal tight junctions, again damaged tight junctions, and the paracellular route, which is the junctions which is causing endotoxemia, again stress, LPS, gut microbiome toxins, antimicrobial peptides, non-digestible. So this is the mucous membrane, the lumen. So if the lumen and the mucus layer is appropriately intact, there is less damage to the normal tight junctions. So it is the mucous membrane which needs to be taken care at the same time of tight junctions. Again, food emulsifiers. So we have more of a fast food, processing food. What are these doing? They are using a lot of food emulsifiers. So when you're using a lot of food emulsifiers, these are the glycerol, monoglycine, polysorbate, this which might be causing chronic inflammatory, and the gut microbiome is releasing a different kind of endotoxins, and there is less small chain fatty acids and flagellal expressions and bacterial inoculation, which is having the inflammation in that. The pathogenic is Shigella and Fusobacterium. There's so much of E. coli and there's so much Shigella nowadays. Shigella we used to read as, only diarrhea and all that stuff. But when we are testing, we have too much of different kind of bacteria at the same time in the gut. Again, how probiotics, genetically engineered probiotics, fiber-rich food, what is this thing can improve because will decrease the metabolic syndrome, inflammation, and atherogenic lipid. So dietary fiber is the key here. Again, food sensitivity. So food sensitivity is what we are looking at when we are testing any of chronic allergies. You see a lot of people coming with, oh, I'm sensitive to this food, I'm sensitive to this food. So the food sensitivities which patients are having, maybe the gut is reacting differently to each, extra coating or preservatives that has been used, color, preservations of the food. So they might be having allergic to that food. Sensitivity might be causing to the processed food, not by the food by itself. So we do test a lot of food sensitivities at the same time in terms of inflammation. Again, there is an immune complex reaction. It's not only the microbiome, it is a detailed immune complex reaction which happens with the cytokines and tight junctions proteins, tumor necrosing factor, killer cells, and all that. So we do test these immune complexes also now, other than the regular for diabetes and cardiovascular. We are testing immune complexes also for the gut, for the dysbiosis. So that is the intention of keeping is like, what is an immune complex and how can we be tested? So assessing antigenic interstitial permeability, we know we do test IgG and IgA, right? So what are we understanding between IgG and IgA? Somebody asked the question about, oh, we are testing IgG. But what is the IgG? So we know that there is some kind of a reaction which is producing more of an IgE or an IgA. So here, epithelial cell damage. So IgA, I would take it as an epithelial cell damage marker if I am checking my IgA. And then we have more IgG and IgM testing for the occludin and for the zonulin, which is the tight junction background. And then we in the feces, calprotectin. So this is the same thing, which is stable in the feces for up to 7 days at room temperature, easily detected. Indirect marker depending on the presence of intestinal inflammation. So these are the diagnostic tools which are available in other countries. It's not available here, but this is the data we are backing up for dysbiosis or IBS or why the gut is the main factor, because we have enough proof of this testing. And for the lipopolysaccharides also, we have specific bacteria. So this is a kind of testing which we do with food and microbiome and complementary system. So in the complementary system, we do have a complementary cascade of C3. So we have to the testing as well as, because C3 is part of the innate immunity, can produce recruitment amount of antibodies generated by adaptive immunity system. So complement activation, C3d levels significantly higher in acute myocardial infarction. So when they saw acute myocardial infarction, we only do troponin levels and all that to see whether to take care of the patient with a stent and all that. But chronic inflammation, they did a study. This is a study in 2018. Okay, inflammation and tissue injury, complement activation in acute MI, an early marker of inflammation and tissue injury. So C3d levels have been higher in AMI patients. Increased levels occurred previously to a classical marker for myocardial damage. But unfortunately, insurance doesn't cover all these things in the preventive management. So when we are taking insurance patients, it doesn't cover, so it becomes too expensive in the pocket for the patient. But in hospital also, the doctors are not ordering because who will take care of the cost? So Candida, again, we know enough information, grows when good bacteria is suppressed or their immune system is weakened. So Candida, we all live with Candida, but who is having this gut candidiasis is when their immune response is low, the Candida can multiply in different parts, mouth, skin, and gut. So fungi, again, thrives in healthy gut, can also has an intestinal damage causing IBD. Immune system keeps fungus in check. When system is off balance, disease can occur. So Candida albicans is a strong, again, immune response. Yeast in its normal rounded state allowed to people to remain healthy. Again, Candida invasion or intestinal damage can cause IBS. So what is again zonulin? And people ask about gluten. So what is the story behind gluten? So the gluten, again, is damaging the gliadin and intestinal bacteria protein. So that's what the story is happening with gluten. So that gluten, which is a protein which has been modified and genetically modified with that. Now what is it causing? The gliadin protein, which is interfering in the intestinal bacteria, are the main triggers for zonulin damage and zonulin disease. So this is where the gluten come in place, which is a gliadin and gluten. You can look at the papers. Again, overview of zonulin, protein synthesis in the intestines and liver cells, key biomarker for intestinal permeability. Elevates levels of zonulin is associated with multiple sclerosis to obesity to inflammatory bowel disease. So we do testing for zonulin in our blood. So higher levels of serum zonulin may rather be associated with increased risk of obesity. Again, waist circumference, diastolic blood pressure, fasting glucose, and increased risk of diabetes. So this is a study paper with higher zonulin levels in the blood can cause. So zonulin IgG antibodies resolves problems with zonulin protein ELISA testing. There's an ELISA testing. We have a finger point testing. Sample test is serum or blood test. Sample typing is serum IgG concentration is stable, shows the measurement. Positive rate eliminates zonulin blocking and low positive rate. So this is the cross-reactivity of all that. And then occludin, again, is a Cre-protein junction, transmembrane domain, tight junction, which is biomarker for the intestinal permeability. So these are the two testings. So together, zonulin and occludin are the gatekeepers for tight junctions. When functional properly, they prevent large molecule from crossing the intestinal barrier into the bloodstream. So these are the markers that we test. So gram-negative bacteria, again, it's about the LPS, which is causing the thing. Again, let's repeat. Again, how between microbiome and the immunity, interleukin 6, interleukin 9, why there is a cytokine production directly. So LPS, again, is secreted everywhere and interleukin, that muscle pain. So we have a lot of fibromyalgia patients. So this is what I learned with my chiropractic doctors. So they do tend to have a muscle pain, and they looked into this as well. Chiropractic physicians also started looking at these testing for muscle pain, and that's where we were working together, and that's what we happened, saying that it can cause pain. So bacteria-produced tryptophanase leads to tryptophan and serotonin melatonin deficiency. Yesterday, for the Finum patients, students, doctors, we were looking at these, melatonin deficiency. So LPS also plays a role in the same sensitivity. So this is what happens in the leaky gut. So when those increased endotoxins are getting absorbed, they are leaking into the bloodstream, not to the externally, but into the blood circulation. And the transcellular pathway and the intestinal bacteria and chronic renal failure. This is a study in 2009. Gut and intestinal bacteria is in chronic heart failure. Okay, again the test, these are the tests which we do in my clinic there. Food antigen, C3D and enzymes. Okay, test, don't guess, but here we have to guess because of the symptoms. We don't have it. Early detection is critical. Okay, this is one of the, I have 3 cases before and after treatment. This is the Candida is positive, and then IgA is positive, which is called a gut barrier panel. Okay, zonulin, occludin, and LPS. So this was positive, and this was a clue that the patient was going through an leaky gut syndrome. And then we looked at lipids. So one thing I want to take is we have to, again, I hope soon the Indian system of diagnostics will change testing cholesterol. Okay, cholesterol needs to be checked differently, called high, direct low density lipoprotein. So it is indirect and direct. So these are the cholesterol testing, also non-HDL, apoprotein B, lipoprotein B. These are all available in India, except the direct HDL. I checked the lipoprotein A. I already checked the apolipoprotein B. I do these testing here. And these are the clues for us, which is kind of, what are we doing if what we are doing. We'll say, oh, you're testing too much. I have to test. I have to know whether you have it or not. Because patients say, oh, you're ordering so expensive tests. But we know why we are testing. If you don't know why you're testing, then there's no point. So that's why we do test lipoprotein A, apolipoprotein A, and all that. So the advanced lipid testing is direct LDL, HDL, and ratio. Please, when people come with a lipid profile, calculate the ratio with lipid ratios with total cholesterol with HDL and HDL with triglycerides. So this ratio plays a significant role for us. And apolipoprotein, metabolics, same glucose, homocysteine, and hsCRP. So this is the ratios and direct LDL. So again, definition, high hsCRP. Why are you doing high hsCRP? Because acute phase inflammatory protein associated with atherosclerosis. Why doing glucose? Because of the risk, HbA1c, and homocysteine. And we have covered enough homocysteine. And these are the second, again, case. We did the treatment. This is the second one. Again, he had both 3 positives, and LPS is positive. And then this is the labs that we do. This is how we get in the US. This is what I thought one of the patient, I take this, and direct HDL, triglycerides, and non-HDL. We get it together as a pattern like this, and which has metabolic tests, inflammatory test, and homocysteine right there. So direct LDL cholesterol distinguishes between LDL in blood versus LDL estimated equation. So this is the equation. If it's not having it, there's a formula to calculate it. If we have, this is a takeaway, there's a formula to calculate your own if your lab is not providing it. So apolipoprotein B, people asked why you're testing this. I thought I'll just put a slide. Slides will be shared with you, which can cause atherosclerosis. Again, this is a study behind the ApoB containing lipoproteins to both deposit risk and treatment. Okay, sticky lipids. So nothing but it's a sticky lipid. Okay, elevated up to most of the population. So blood clots. So when you become sticky, then the blood clots. Again, plaque impaction with the ratio. The ratio is why important? Because high risk has a different ratio. So the ratios are very, very important than looking HDL by itself, LDL by itself, or what is the total cholesterol with HDL ratio. We have enough data. Optimal, the ratio should be 2.8. If you don't want to remember this, just say when patients is coming, the optimal ratio should be 2.8. Again, HDL to triglycerides ratio. I look at more triglycerides rather than total cholesterol because that is more sticky and it's causing and carbohydrate source and alcohol source. So you can make a more difference to the patient than looking at the triglycerides and just putting on them on statins. High risk CRP, we have enough inflammation, free diabetes. Again, this is what the CRP goes. Somebody was asking CRP, okay, 2, but right now we changed the data to 1. Before it was 2, but anything above 3 is caution. So 1 to 2 is okay. Anything above 3 hsCRP, you need anti-inflammatory actions. Okay, glucose and A1C, everybody knows about A1C. Homocysteine, again, why do we replace B6, B9 and B12? Everybody asks, why you take this B6, B9 and B12? Because of the homocysteine. Again, this is a cycle of a homocysteine. The reason you need to take vitamins because of the homocysteine. So prevention and regeneration, vitamins, supplementation and dosage. Why we need to know. If you don't know why, everybody will be taking, Centrum Silver, everybody will take that doses. That's not appropriate. So I take them off of the multivitamins that they're taking and I give them very specific according to homocysteine and according to hsCRP because that's not dose appropriate. That was old, but right now we know what we are doing with the dose appropriation. So what do? Reset the diet, remove unwanted pathogens, replace digestive enzymes, stomach acid, regenerate damaged intestinal epithelium, re-inoculate with quality with pre and po, reintroduction of certain foods, okay, retain your health, gut activity. So this is what we do in of those patients that we said before and after. This is what we did. We changed their diet. Alpha-lipoic acid we gave. Anybody who is having an IVC, alpha-lipoic acid, berberine, and we gave these probiotics additionally with omega-3 fatty acids. And this is for the homocysteine. This is what we gave. Niacin, red yeast rice, phytosterols, and pre and probiotics also for homocysteine. And for candida, this is what we do. That's why we use garlic, because of that. SBI probiotics, and then for the zonulin and occludinin, zinc carnosine. Somebody is asking what kind of zinc. I use a lot of zinc carnosine, L-glutamine, or curcumin. So always use. Why I'm using it is you need to recover and regenerate the barrier of zonulin. So this is what we use when there's this thing. LDL, lower this thing. Again, I will share the combined exercise, and we all know how exercise help. And the same patient, after day 181 days, patient got better. The test came back as negative. So these tests do come back and we do see a difference. And that's why our data is evidence-based medicine is what this is. We might not be having too much volume, but I have enough data of my own patient. So again, direct, we put this chart and then the same thing. We did this a second patient. There's a third patient of gut protocol, what in months 4 to 6 months, first 3 months, how do we do it? And then the patient became negative. So again, last but not the least, you will be coming across all kind of access now. We have so much data right now, gut, muscle, gut, bone, gut, liver, gut, lung, gut, heart. So all axes are going to come up with more data and with more microbiome coming. So please take care of gut. Let's take care of gut and trust your gut. And thank you so much.